Okay, welcome. RSI, meds, and method. Rapid sequence intubation will cover all the medications, but more importantly, the method. One of the first things that we're expecting is mastery of the basics. You have to be able to master the basics. You have to be able to master bag mask ventilation. Super important. Matter of fact, probably the most important part of the entire lecture. Video laryngoscopy, if you have it available. Conventional laryngoscopy is considered the gold standard. Again, if video is available, great. If not, conventional laryngoscopy is the gold standard. Familiar with all of your extraglottic airway devices and how to use them and when to use them is paramount. That is life-saving. And then lastly, surgical airway technique. Again, last effort, but very important that you're comfortable with doing this and you know when to apply. So you have to be able to decide when to intubate. So you have to make the decision of, are you going to intubate, and then when you're going to intubate. So that requires you to rapidly assess your patient, determine their needs, the urgency of the situation, a lot of considerations there, including your EMS runtime, determine which method that you're going to do it if you decide to do it, and that's going to be based on your ability to predict if there's difficult airway or not. You're going to have to decide which drugs you're going to use and what doses, and then you're going to have a plan for a backup should you be unsuccessful. Next, you have to be able to identify the difficult and failed airway. The most important piece to this is who's going to be difficult. Avoid stepping into those cases, not being prepared for that. It really comes down to two areas. We talk about this in terms of, can I ventilate them and can I oxygenate them? Or more importantly, in this slide, it will be, I cannot intubate them, and I cannot oxygenate. Well, that would be the worst case scenario. And in that case, you might end up in a situation where, you just need to do an airway. Okay, fine. RSI, yes. You might end up in a situation where you start RSI and you determine you can't intubate them, and now you cannot oxygenate them, and now you have to go to a secondary option. And can an extraglottic airway or supraglottic airway device help you? Also, you may be able to oxygenate them, and you might not be able to intubate them, in which case that would be a great candidate for a supraglottic airway. So again, these are the big problems, is you've got to be able to decide who can you ventilate and oxygenate. Can you not intubate them and oxygenate them, or can you not intubate them but you can oxygenate them? So a couple ways to do this. You can look at the mnemonic lemons, which is predicting the difficult airway or laryngoscopy. So you'll look at the patient, you'll say, oh, they have a small mandible, a large tongue, they have large teeth, they may have a short neck, they may be bleeding, there may be some traumatic changes in their anatomy. Also, bones is another submnemonic, which means beard, obstruction of the airway. Do they have neck immobility issues? Are they edentulous, and do they snore? Those are traditional things that are red flags, but you can look at them pretty quickly and decide. If you had the time, you can do the 3-3-2 rule, which we'll go through. Mallampati score, which is nice to have an idea of what that's all about and what it means. Clearly obstruction, we talked about it above at the look piece. Neck mobility issue, C-spine immobilization, difficulty moving the patient, and then your situational awareness of the scene and your capabilities and how much time do you have. Next is 3-3-2 rule. And this is where you'll have them open the mouth. You can hold 3 fingers in, and that means there's enough real estate to work with. I go from there to the next figure B. The tips of the finger will extend from the chin all the way back to the hyoid cartilage, or hyoid bone. That's going to end up being a nice ability to move everything around in the mouth. They have a decent amount of real estate again to work with. And then lastly, from the hyoid down to the top of the thyroid cartilage, which is going to end up being 2 finger breaths, so 3-3-2. Next, the Mallampati score, class 1. Clearly, you can see everything perfectly wide open. Would love to always see that. Not necessarily the case. Class 2 would be, I can see everything pretty good. Not quite able to see all of the back of the paratonsillar fossas or what was left of that, but everything looks great. Again, I would love to see that. Class 3 is probably the majority of our patients. Again, I can't see the tip of the uvula, which I can see on clearly class 1 and 2, but again, everything else is decent. I mean, I would consider it moderate difficulty, but again, I would like to see that. Class 4, I cannot see any of the uvula whatsoever. Completely, all I can see is the hard palate and the tongue, and again, those people are going to be very difficult. You'll find that with some manipulation, positioning, you can actually make a 4 a 2 or a 4 a 3, and that's what we want to shoot for. Next is being able to ventilate the patient with a bag mask. Roman's a great mnemonic for that. Clearly, the mnemonic is radiation and restriction. So in this case, restriction, well, that's angioedema. That's a guy that took an ACE inhibitor that was told not to, and he did so anyway, and he came back with that presentation. Obese obstruction, obstructive sleep apnea, these are people that have a lot of extra tissue floppy around, blocking the airway, difficult to bag them. And then obviously, if you have a difficulty with the seal of your mask, that'd be a person with a large beard. Their Mallampati is a 4. Most of them are going to be males, by the way. So anyway, if you have all that combo together, you're going to have difficulty ventilating the patient with a bag mask. Okay, failed airway. Failed airway exists when any of the following conditions are met. Failure to maintain adequate or acceptable oxygen saturation during one or more attempts of intubation. Number 2, 2 failed attempts at oral tracheal intubation by an experienced operator or intubator. Number 3, the single best attempt in all conditions optimal, and you fail to intubate, and that is also considered a definition of a failed airway. The 7 P's of RSI. Normally we tell our colleagues proper preparation prevents poor performance. That's why you're here. Within the 7 P's of RSI, we have preparation. So that's when you're getting everything ready. You're getting the rig ready. You're getting your team assembled. Everybody knows their role and what we're doing. Simultaneously pre-oxygenating the patient. In addition to that, simultaneously possibly positioning the patient, and we'll get into some of that as well, depending on the severity and the urgency of the situation. The pre-oxygenation topic, obviously super important because we have a hemoglobin dissociation curve that in the most perfect scenario, you're able to oxygenate somebody and pre-oxygenate them up before you paralyze them, and they can have apnea for 4 minutes all the way up to 6 minutes without any significant desaturations. Again, that's the most perfect scenario in the OR. Patient is NPO, everything is perfect. In our world, that's not the case. We're dealing with situations that are completely emergent, and therefore our pre-oxygenation timing has to be very exact, because our apnea time for intubation is probably 1 to 2 minutes. So don't get in a hurry, but just make sure you're pre-oxygenating effectively, which means, non-rebreather. Maybe I have them on a nasal Kenya plus a non-rebreather. Maybe I have them on CPAP, whatever the clinical scenario dictates. Then we're going to pre-intubation optimize. Well, that used to be called delayed sequence intubation. We pre-intubate optimization to prevent complications. So if I have a patient that's hypotensive, I want to try to increase their blood pressure. Multiple ways to do that. If they're hypovolemic, then obviously IV fluid bolus. If they are in shock from hemorrhagic shock, not only IV fluid bolus, but possibly blood products. If they're septic and they need a little more pressure support, maybe a push dose epi is in order, or all the above. So my point on that is take a look at the vital signs. Make sure that when you go to give the meds that you've got the best clinical situation that you can work with, and that's all. Sometimes that's all you get, but just make sure you try to optimize that. Next is going to be induction with paralysis. We want induction before paralysis because basically we want the patient to be asleep. There's more to talk about this on the next slide, but we want to make sure that the patient is not aware of being paralyzed. We're going to then give them the paralytic. We're going to then place the tube, and we're going to prove that we placed it both direct visualization as well as other methods, in-tidal capnography, bilateral breath sounds, etc. And then lastly is post-intubation management. So those are your 7 P's of RSI. Very important to kind of keep that sequence in mind. Induction with paralysis. A little topic here. Induction is a process of sedating a patient, but we're going to deep sedation levels, not moderate, not for procedural purposes. So the doses of the drugs are a lot more. Again, the point being is we want them to lose consciousness, we want the respirations to decline, we want to have control over that patient, and then we're going to give them the neuromuscular blocking agent. The timing between the sedation and the neuromuscular blocker would be pretty much, takes around 1 to 2 minutes for the sedation to really work. The neuromuscular blocker will actually take anywhere from 45 to 60 seconds. So once you push those meds back to back, you're obviously in and you're prepared to do the intubation. Give yourself ample time to notice that the patient is completely relaxed. They're able to be intubated successfully without any muscle tension around their jaw. They don't have trismus, they don't have any issues with that. They certainly cannot have a gag reflex when you're doing this process. If that's the case, either the meds did not go in or that was a dosing issue, they've got to troubleshoot that process. Positioning of the patient. Again, one of the more important items that gets overlooked because it aligns up the anatomy and it makes everything comfortable. At this point, you position the patient for intubation. You've given them this, obviously you may have already pre-positioned them, but you may have to readjust once you get them paralyzed and sedated. You got to keep in consideration cervical spine immobilization like in a trauma patient. Clearly make it easy on yourself. Get that bed height up to where it's comfortable for you so that you're able to focus on the job at hand and not your back that's bent forward. Very often you can adjust the head of the bed to have the head slightly elevated and have the patient extended all the way back to the top of the stretcher so that you have room to work and you're not leaning completely over the bed or the stretcher to work. Your assistant, your second set of hands, is going to be available to pass equipment to you. In a trauma patient, more importantly, to hold C-spine while you're able to intubate them, take the collar off. They're working from below you, never at your side or behind you. They're always in front or below. They will be able to hold the position of the head. They'll be able to help perform any type of laryngeal manipulation. We call that BURP, backward, upward, rightward pressure. We'll kind of talk about that in another slide. And retract the corner of the mouth during intubation. Super important. And as you guys know that have done this, that right there makes or breaks your confidence and your timing if you can't do that and you can't see. So every bit of help that your second set of hands can do makes you successful. Positioning of the patient, super important. So to give you a quick idea of what a normal patient would look like on a hard board or on the floor would be figure A. You've got the oral axis, the pharyngeal axis, and the laryngeal axis, and all of them are completely opposing one another. What our goal would be to get to figure C. How you accomplish this is basically you raise the occiput, the base of the head, not the neck extended, but the base of the head. So you put something underneath there to give them a little bit of a lift. And again, this is only in the non-trauma patient. So with that, what's the height? The height could be anywhere from the thickness of a dry eraser to maybe a towel that's folded in half. You'll have to kind of like adjust that based on your patient as well as the surface you're working on, but you raise the head of the bed so it goes under the head, not under the neck. Once that occurs, you just do a little simple chin lift maneuver and you can immediately get figure C, where the oral axis, the pharyngeal axis, and the laryngeal axis all will line up, and when you go to intubate them, you'll be able to see the cords immediately. It's a straight shot, take a lot of the pressure off of the operator. To test this out, the next time you have a mannequin and you're doing this ACLS or whatever, try doing it without that. Just intubate them straight up, don't do this positioning thing. Then do the exact same mannequin with positioning by putting something under the head of the mannequin and doing a chin lift. And you'll notice that your physical effort is decreased by about 50%. And if it works on a mannequin that well, it's going to work on a human a lot better because we're more pliable. So therefore, positioning is super important. I think we overlook that a lot of times, especially when we're in a hurry and we're trying to get this done. We got a lot of distractions. This slide is basically what you want to see is figure A. This is based off of a classification of what you see when you look in the oral pharynx is called the McCormick classification. You basically have the most perfect visualization of the chords and the epiglottis, the whole airway on figure A. B is not bad, but not totally optimal. C is probably not a good move because you're guessing if you place the tube. And then D is impossible. So by positioning the patient properly, you can take a C or a D and make it a B or an A. By doing a little bit of tracheal manipulation, and what I'm saying by that is you're basically grabbing your laryngoscope is in your left hand, your right hand is free to place the tube. Before you place the tube, take your right hand, your thumb and your middle finger, and you can move the trachea around with your index, middle finger, and thumb. You can move the trachea around to where you can see the chords. All right, and so we call this backward, rightward, upward pressure, or back up, right pressure. It doesn't have to be in that order. It just basically means go side to side, up and down gently, and you can reposition the chords. Once you do this, you take your finger, hold it in the spot that you want it, tell your assistant to basically take their hand and place it over your hand and hold that spot or hold that position. You then grab the ET tube with your right hand, let go, your second set of hands is holding the position, and then you place it. And so this makes you very successful. Make sure that you get this clear. This is not the Selleck maneuver. You're not pushing down on the cricoid cartilage to the point where you're pinching off the esophagus to keep air from going into the stomach when you're bagging them. That's a whole different deal. Selleck maneuver is not adjustments like we're talking about with backward, upward, rightward pressure. So neuromuscular blockade and sedation. Again, sedation comes before neuromuscular blockade. What does it do? It induces unconsciousness. Deep state sedation reduces the pain response, which is important. It produces a retrograde amnesia in most cases. Very important for the patient. Paralytics are going to paralyze them completely, decrease their ability to breathe, but they're wide awake. So that's why we want sedation to be in this sequence. And pain medications on the front end is always a good thing. Certainly may want to consider it after you intubate them as well. Neuromuscular blockade indications. If you look at RSI in general, there is about, say, maybe 60 to 80, depending on which textbooks you look at, indications. So anything you can think of can be an indication. Basically, to keep it really simple, it's down to multi-system trauma. I know it's going to be an issue. We want to tube them, secure their airway, so that's one variable we don't have to deal with, especially if we're flying the patient. Second item is head injuries with GCSs that are 8 or less. I would say 8 or less is the kind of the gold standard. If you try to practice, given the answers of a GCS of 8, you would clearly figure out pretty quickly that that's somebody that's not very responsive. However, if you've got a 13 and they're decreasing to a 12 or a 10, that might be your indication. Burns to the upper airway, clearly a no-brainer. Those people need to be intervened on sooner than later. And then lastly, the whole reason you do the blockade is so that you don't have to deal with trismus. The last thing you want to deal with is you sedate somebody, you try to intubate them, and their jaw's tight and you can't open their mouth, you can't place the tube. So the whole reasoning behind rapid sequence intubation was to allow you maximum success, and that includes neuromuscular blockade. So again, many, many more indications. These are just a couple. So one of the second line agents that we use is succinylcholine. It used to be first line for many years. Again, the dose is 1.5 milligrams per kilo for a total max of 150. It is a depolarizing neuromuscular blocker, unlike rocuronium, which is a non-depolarizing neuromuscular blocker. The difference is that the succinylcholine actually binds with the receptors at the motor end plate and it produces the blockade. But when it does that, it gets an initial stimulus of the receptor, and that causes fasciculations. And so once that fasciculation is completely gone, then they're completely paralyzed. So people often think they're having a seizure. They're really not. There are fasciculations. They are expected, and that is something that is common. It can cause hyperkalemia. Those fasciculations are the real reason for that. You have to be careful with patients that have hyperkalemia. We'll kind of go through some risk here in a moment with that. It does cause rapid paralysis, less than 1 minute. That's a positive. and it's very short acting, and that's a positive in case you're having difficulty and you need them to be able to resume their normal respirations and you're going to try to use another technique. But again, there's a lot of contraindications, anything that can cause hyperkalemia, so burns, crush injuries, chronic neuromuscular disorders like the ones listed below there, Becker's, Duchenne's, muscular dystrophy, cerebral palsy. All of them should be red flags. Hey, may not be able to do it. Anything that you've got intraocular pressure concerns about, that's another contraindication. So then again, just second line agent, know it, it's available for our use. If you ever have to redose succinylcholine, just remember that the body responds in a very abnormal way. It takes the succinyl out and it thinks it's choline and basically makes you bradycardic. And so if you ever have to redose sucks, make sure you give a dose of atropine between the two doses, or you will experience severe bradycardia, and that might complicate your RSI. Okay, rocuronium, our number one go-to paralytic. Intubating dose is 1 milligrams per kilo, easy to remember. Time to intubation is around 45 to 60 seconds to achieve paralysis. The duration, however, is a major issue at 40 to 60 minutes, unlike succinylcholine. Therefore, once you push this drug, you're committed to keeping the patient alive by ventilating them for 40 to 60 minutes. It's Class B pregnancy, again, number one drug. The range can vary between 1 to 1.2 milligrams per kilo. We want to keep this easy to remember, so 1 milligram per kilo. All right, neuromuscular blockade, succinylcholine precautions, we kind of touched on those. Again, burn patients. Again, chronic paralysis or neuromuscular disorders. Anything that can cause hyperkalemia, like a crush injury, renal patients, dialysis patients, those people miss dialysis. Be concerned. Anything with intraocular pressure, glaucoma, penetrating eye injuries, be careful with that. And then the next one would be seizures. And that seizures is for every single neuromuscular blocker, not just unique for succinylcholine. And that is sometimes when you paralyze these seizure patients that are prolonged seizing, then you think you've got them under control because you've paralyzed them and you tubed them, but they're still seizing on the inside of their brain. And the only thing that you can rely upon to know that before you get to the emergency department would be their heart rate. In other words, if they're stable and you took care of their airway and you're managing them appropriately, you're ventilating them, they're oxygenating great, their heart rate should be decent unless they're in shock. So if their heart rate is still running at 130s to 160s, and that's what they were running when they were seizing, they're probably still seizing. So really consider some sedation. Add to this en route is more sedation. For us, we're going to put them on continuous EEG monitoring, and we're going to make sure that they're not, in status epilepticus during the process of having them intubated. And then difficult intubations, predicted difficult intubations, major facial or laryngeal edema, and all of those items. These are all precautions for all neuromuscular blockers, not unique to succinylcholine. Just you got to be careful because what we're saying here is know your anatomy, know what you can work with, and if you don't think that you're going to be able to place the airway effectively, then maybe we need to consider a different method. Okay, malignant hypothermia, that was on the last slide. We're going to get into it on this slide. Basically, it's a reaction, it's very specific. You get a high body temp surge, you get rigid muscles and spasms, increased heart rate. All of this is kind of out of the blue. In other words, you tube the person, you use your neuromuscular blocker, succinylcholine, for example, and all of a sudden they develop this syndrome. This will be a very obvious thing. It's very, very serious. It can be treated with dantrolene. We have that available in the hospital. We don't have it available on the EMS rigs, but again, it takes a little while for this to happen. So just be aware of the signs and symptoms of that. They'll get a tachycardia, they'll get really muscle rigidity. They shouldn't be because you paralyzed them. Increased, respirations trying to fight because they're kind of waking up. And again, succinylcholine, very short acting, so it'll wear off and they can still get malignant hyperthermia. So again, don't just chalk that up to, oh, they're waking back up. It could be a reaction. Okay, sedation, etomidate or ketamine. Etomidate indications would be head injuries with suspected ICP, pregnant patients, CHF or any cardiac disease, patients under 36 months of age. Ketamine indications would be bronchoconstriction, so your COPDers, your asthmatics. And then septic shock or hypotensive patients, as ketamine has very little vasoactive properties, so therefore hypotensive patients don't drop their pressures. Etomidate, by the way, also does have great hemodynamically neutral properties, but ketamine is preferred. And violent combative patients, which we already use ketamine for indications for sedation and control over them, the doses for intubation, however, are going to be different. Okay, so post-intubation sedation, again, Versed is our friend. We can even use it if we had to for sedation during intubation. But again, 0.1 milligrams per kilo, up to 2.5 from birth to 11 years old. Again, great, especially if you use ketamine as your induction agent, because sometimes people will come out of the ketamine and they'll be really wild and crazy. This will calm that whole, we call it a re-emergence phenomenon, and it'll calm it down. 12 and older is pretty much adult dose, 2.5 to 5 milligrams. You can repeat it for a max of 10. That's pretty much where the majority of these patients are going to be. Ketamine, on the other hand, if you redose it, clearly it's 1 milligram per kilo. It's on the lower dose of our 1 to 2 milligrams per kilo IV dose. And again, you want to, you don't want to max it off of their total body weight. If you're dealing with a teenager that's big, you might want to consider using the ideal, or an adult, for example, like a really big obese person, you might want to consider using ideal body weight instead of actual body weight, or just max your max dose. That way you don't overdose them on ketamine. You're going to have to be really good at bag valve mask ventilation. Your anatomy is going to need to be high probability success, not like massive facial trauma and you're worried that you're even going to be able to find what you're looking for. Could not have any contraindications, so no absolute contraindications for RSI. Basically, trismus is why we use it. Intact gag reflex, very combative patient due to illness. Very hard to deal with those patients, but that's why we do it. You want to make sure your drugs are the right dose and the right ones for the clinical situation. You're going to get control of your crew and the patient treatment area. You're focused on one point. That point is you're going to do RSI, and you need all hands on deck, and you need your second set of hands helping you. You're going to have your most experienced medic at the bed doing the procedure. This is not time for your ego. You'll get your turn down the road if you're new at doing this, but make the most experienced person there, because that's, you're taking the patient's ability to breathe away. So you need to have your best skill person on the job. You're going to lay them down. You're going to have 2 ET tubes. You're going to have a supraglottic airway ready, a cric kit ready, atropine for complications and or need, and you're going to draw your medications up, and you're going to re-verify that. Maybe double check your doses, triple check your doses. You're going to make sure that you give them some post-intubation sedation once you verify tube placement. The last thing we want is somebody to remember everybody's name in the squad and all the stuff that they said about them on the way to the ER, because that has happened. Make sure your IVs are working. Again, triple check your weights and your meds. That's going to be super important. Consider pain meds as an add-on. You're going to give your meds. You're going to induce them with sedation meds. Give them the neuromuscular blockade. Once the jaw is flaccid, suction the airway, you're going to come in and you're going to intubate them. Again, video laryngoscopy if you have it. Direct laryngoscopy, most common. You're going to watch the tube go through the cords. You're going to, again, verify that visually. Balloon goes up. You're going to listen for bilateral breath sounds. You're going to record their capnography, and you're going to basically confirm placement. Allow only one attempt from one person for ET intubation, especially if it's a really good attempt with everything as good as you can get it. If unsuccessful due to your run times and also other issues, you might want to go immediately to a supraglottic airway. Secure the tube, post-intubation sedation. Consider a second dose if your transport times are long. Confirm tube placement again, right after the procedure. Probably good to also reconfirm it before you hand off the patient and move them from one stretcher to the other. Most of the time, the tube dislodge situation occurs on transfer. Be aware of malignant hyperthermia, and then observe the patient for signs of pain, which will be tearing, tachycardia, tremors, other symptoms of pain, including movement if the paralytic wears off. I hope this kind of keeps it focused and simple and not a really prolonged lecture, but gives you the nuts and bolts that you need. More on this on hands training with your EMS captains and myself or the other EMS chiefs. Thank you.